So, good evening, ladies and gentlemen, and thank you very much for coming and listening to this online version of this very interesting topic, which is also something new for us here because we have been working with it for the last few years, and the results are very exciting. So, the question is hyaluronic acid a new emerging aid in regenerative procedures? Something. Right, something. So the mechanisms of how hyaluronic acid works in wound healing is very specific. It is actually the major component of the extracellular matrix, and it's in a native state exists as a high molecular weight molecule. What is the difference between a high molecular weight hyaluronic acid and a low is in how they function. The high molecular exhibits higher viscosity. There's a longer resistance time, so it stays longer in the area of application. It has a higher biocompatibility. It also shows anti-inflammatory effects, and additionally, it shows bacteriostatic effects. And additionally, the high molecular weight hyaluronic acid inhibits angiogenesis, decreases interleukin-1 and 6, the pro-inflammatory interleukins, as well as tumor necrosis factor alpha and prostaglandin E2 production. On the other hand, the low molecular weight hyaluronic acid is reported to stimulate angiogenesis and unfortunately induces inflammatory effect. But we will see later that this low molecular weight also has many other positive effects in addition to stimulating new blood vessel formation. So if we look at the high molecular weight hyaluronic acid, it is capable of accelerating new bone formation through the differentiation of mesenchymal cells, which is very important when we do bone grafting. And additionally, if there was another very interesting study published a long time ago when they examined calvary or osteoblasts cultivated in low compared to high molecular weight hyaluronic acid, and we see that there is, with the high molecular weight, there is a significant increase in, let's say, alkaline phosphatase, which is a marker of mineralization of cells. So there is a biologically speaking, we see that there's very positive effects of this molecule on pre-osteoblasts and mesenchymal cells and on mature osteoblasts as well. A very interesting finding is that hyaluronic acid actually induces a new vessel formation, so it induces actually angiogenesis. The only thing that we have to see is that it's much better if it's combined with demineralized bone matrix. So there is a kind of a coupling effect, or let's say a synergistic effect between the hyaluronic acid and a bone grafting material. And we know that, and we see this in this study by Rains and Boyne in 2011. And if we look at the number of blood vessels, we see that actually the low molecular weight hyaluronic acid, which is here in this bar here, it has exhibits in the combination with demineralized bone matrix with allogenic bone. It significantly increases the number of vessels, the density of vessels, the thickness of the vessels compared to, let's say, to a empty defect in the tibia, which they created. So there's a very positive effect in vascularization of the grafting material when it's combined with hyaluronic acid. So what about the applications in dentistry of this molecule? Well, recently there have been a few review articles. One of the first one is in 2015 by Bertel and the group, where they looked at hyaluronan, which is also the same thing as hyaluronic acid, in non-surgical and surgical therapy. And what they found is that hyaluronic acid seems to have a beneficial, generally moderate effect on pocket depth and bleeding and probing. And also it seems that the majority of the clinical studies describes a beneficial effect of hyaluronic acid on bleeding and pocket depth reduction. So there is a clinical idea that this material can help in non-surgical and surgical therapy. Another study published just recently in 2016 also says when they analyzed 20 studies for different indications, non-surgical, surgical, they looked at the patients with periodontitis that the application of this molecule has positive effects on resolving pocket depths and gingivitis and significantly improving their quality of life. So there is these two review articles showing that there is a positive effect in applying this molecule in the treatment of patients with periodontal disease. And if we look at one of the most recent studies on animal studies in the dogs, where they used as a non-surgical periodontal treatment in dogs, what they showed is that if we look at the charts here, that scaling and root planning with the addition of hyaluronic acid achieves better results than just scaling and root planning by itself. Also, clinical attachment gain is higher. Also, there is less bleeding on probing, and there's a better index of the gingival index, which is very positive. Of course, when they added this brain-derived neurotrophic factor, they had an additional effect in combining this. But hyaluronic acid, high molecular, which is anti-inflammatory by itself, induced changes, and although statistically not so much significant, changes that were higher than just scaling and root planning, at least in this animal study. When we look and we talk about periodontal regeneration, we know that we can achieve with various materials very nice results even after 10 years of teeth that are at the brink of extraction. Example in this case, where we after 10 years we see that there's only 3 to 4, maximum 4 millimeters of a pocket depth and complete closure of the intrabony defect here. Well, how does hyaluronic acid, how would it work in periodontal regeneration? Well, first, there's this very interesting study on cells, humans, fibroblasts from the palatal and from the gingival margin. They looked at how hyaluronic acid will interact and what effects it will have on these two different fibroblasts from different areas. They used 2 formulations. They had a native cross-linked hyaluronic acid, which is the one that we're talking about today. And they used a different formulation where it was additionally cross-linked to a ratio of 8 by 1. I'm sorry, the first one is a non-cross-linked hyaluronic acid and the other one is a cross-linked hyaluronic acid. So what they found in the results is that both preparations of hyaluronic acid strongly increase the proliferation and migratory abilities of human palatal fibroblasts and human gingival fibroblastic cells, which we can see here. H1 is the native form and H2 is the cross-linked form. Both induce proliferation, so there's an increase in the number of cells after the application of this. And the conclusion is that the migratory and wound healing property of cell types involved in soft tissue wound healing following regenerative therapy, that it is enhanced by the application of hyaluronic acid. What is also interesting, that the application of hyaluronic acid does not impair the healing process by prolonging inflammation or causing excessive MMP expression at the repair site. So this is very positive. So you have very nice soft tissue, potentially very nice soft tissue healing. Let's see how hyaluronic acid works on periodontal ligament cells. Well, they used again the non-cross-linked and the cross-linked hyaluronic acid, what we are talking about today. And what they found is that non-cross-linked and cross-linked hyaluronic acid maintained high PDL cell viability, increased proliferation, and early osteogenic differentiation. However, hyaluronic acid consistently was associated with a decrease in late osteogenic differentiations of primary human PDL cells, which we can see here by alizarin red staining, that these PDL cells in the control normally mineralized, and by adding in the late stages hyaluronic acid, there is a decrease of mineralization of these cells. Well, I wouldn't say this is so bad, because although we know that PDL cells are also a niche and a source of cells that will differentiate also into the bone and probably into the cementum lineage, but it's very interesting that in the beginning there is a very positive effect of hyaluronic acid on the PDL and human PDL cells. Additionally, the same group looked at what is happening if we seed these PDL cells on dentin and then treat them with hyaluronic acid. So they coated dentin disc with hyaluronic acid, and they demonstrated a near 100% survival rate for all samples, which is very good, which means that the hyaluronic acid maintains PDL viability of these cells, and also that there is these on the cross-linked hyaluronic acid on the dentin surface, which we see here on the scan electronic microscope photograph, that there's a bigger elongation of PDL cells. A bigger elongations mean there is much more spreading of these cells and much more on the surface of the dentin, which could have a positive effect also in periodontal regeneration. Now, why is this so interesting, and why is this study in 2014 on the importance of CD44, a marker, a receptor, a marker a very important receptor marker? Because it was shown that PDL cells proliferation and mineralization, if we do a CD44 knockdown, and here are the cells immunohistochemistry, we see CD44 in abundance in the PDL space, and many PDL cells are stained with CD44 antibody. We see that there's a decrease of CD44 in the PDL cells, and also what we see that there is a decrease in mineralization of these cells. Now, why is this important? Well, it is important because the main receptor for hyaluronic acid is CD44. So CD44 is the main receptor and the predominant receptor for hyaluronic acid, which means that if the PDL cells are full of CD44, it means that the hyaluronic acid will attach to the PDL and exert its effect. And in this study, in the dog model, where they looked at how high molecular weight hyaluronic acid could function on regeneration of the periodontium in a dog, that they found that high molecular weight plays a role in the early phases of periodontal regeneration, signaling through CD44. So in the human also, it seems that because the PDL cells have a lot of CD44, CD44 expression, which is a receptor for hyaluronic acid, that there is definitely a positive effect of hyaluronic acid on the PDL cells. And additionally, CD44 immunoreactive cells on the dentin surface may possess the potential for the formation of cementum and periodontal ligament. So there's clearly a synergistic effect. And if we look at if we look at how on figures A and B here, we can see that the hyaluronic acid by itself is able to induce new bone formation and new cementum height. So there's definitely a positive effect of applying hyaluronic acid in periodontal regeneration. Now, when saying this, there's a publication in 2013. This is the only one that we know, and they did a randomized clinical trial comparing open flap debridement and open flap debridement with the application of hyaluronic acid. And what they found is that if you do just open flap debridement, there is only let's say 0.9 clinical attachment gain. But if you use the hyaluronic acid, there is 1.9 millimeter of attachment gain. So there is there's almost double of clinical attachment gain if we use the hyaluronic acid in the intrabony periodontal defects. And the material that we use for this is this HYADENT BG. It's a cross-linked hyaluronic acid, which is composed of a cross-linked and a natural hyaluronic acid. Its resorption time is between 4 and 6 weeks. But we have to realize that it cannot function by itself. And all of the studies show us that it cannot function by itself, but that we need another substrate as a bone grafting material to further enhance its ability. There are several actions how it works. It attracts blood, it stabilizes the coagulum and supports tissue regeneration. It has a bacteriostatic effects. It additionally attracts growth factors. It's a fantastic carrier for growth factor, which I will show you later. And then it promotes neoangiogenesis and coordinates inflammation in the healing. And if we see a case report that has just been recently published by Piloni with a 2-year follow-up in a patient where he had a cemental tear, and then they placed this HYADENT, this hyaluronic acid, which is a combination of native and cross-linked hyaluronic acid, and the huge intrabony defect, and placed a collagen membrane over it. In the CBCT radiograph 2 years later, there's a reconstruction of this buccal bone that was here completely missing. And this is really interesting and really, really fantastic. And let's say a typical example, we have been using this over the last, let's say, 1 year for periodontal regeneration. We are doing a clinical study. We will have to wait for a few, let's say, between 6 months and a year to show you the first results on quite a large number of patients. But this is a typical patient we treat with deep intrabony defects on the buccal and the lingual. We see the component of the intraoral component, intrabony component is, let's say, between 6-7 millimeters. And how we do it is we use the EDTA first to remove the smear layer and open the collagen. And then because we rinse it, and now we have a dry surface on the root. And then because we know, and we showed you that there's the CD44 is dominant in the PDL compartment and on the dentin surface, then we coat the root surface first with the hyaluronic acid so it attaches to the PDL cell, the remaining PDL cells, and to the dentin surface. And then we graft the intrabony defect with the grafting material and place another layer of this material over it to stabilize it, because this material has a very nice stabilizing effect on the grafting material, which I will show you later. We close the wound, and when we see the 2-week healing, we almost every time see this rapid healing and very fast and very nice healing in these intrabony defects. Now, additionally, the hyaluronic acid has been published also in gingival recessions just recently, last year, in class 1 single gingival recessions and randomized controlled trial. And they had 2 groups, 15 patients in both groups, and they followed them for a 1.5 years. And what they found is that when they applied the hyaluronic acid with a coronally advanced flap, complete root coverage was in 80% of the cases, and mean root coverage was 94% almost. And when they only did coronally advanced flaps without the application of hyaluronic acid, they had complete root coverage only in 33% of the sites and mean root coverage in 73%. So obviously there is a beneficial effect of utilizing the hyaluronic acid in coronally advanced flaps and Miller class 1 single gingival recession. So there was a statistically significant higher recession reduction attachment gain for the hyaluronic acid group. And which is very nice that there is 80% of complete root coverage when it is applied together, which works very favorably to comparison, let's say, to the studies where they used Emdogain. Typical case of using hyaluronic acid. So there is a very thin biotype here. This patient has a recession with an edge, and we see that he's a strong brusher because he has these root abrasion defects, and you cannot follow the cemento-enamel junction anymore. So and it's a, let's say the old classification would be the Miller class 3 because we have a loss of interdental papilla. And what we frequently use for multiple recession sites, we use this envelope flap technique where there's no vertical incisions, in a full split mouth design. Then we go and deepithelize these papillas here, the surgical papillas so-called. And then there is an application of the hyaluronic acid onto the soft tissue, onto the root surface, coronally advanced flap and suturing, and we will see how after 2 weeks of healing, there is very nice, fast, rapid remodeling of the soft tissues. After 1 year, there's virtually no changes. There is not complete root coverage. A little bit is left here on the canine. Here on this lateral was not so successful. And if we look at the baseline and compare it to the 3 years later, we see that there is very stable results after the 1 year and the 3 years in this patient with very thin phenotype and a very shallow pocket probingness in this case where there's not more than 1 millimeter. Additionally, we have been starting using this material in conjunction with collagen membranes to see if there's an additional effect, and if we complete, let's say in cases where we would need a connective tissue graft, like in this case where there's virtually no keratinized tissue, and we combine it, we use the same flap and the same procedure. In this case, we use the EDTA so we can achieve a nicer and better root surface for hyaluronic acid to attach to the CD44 antigen receptor, I mean. And then we place this collagen membrane here, suture it in a coronal position, and we always see these 2-week healing very nicely, and hopefully in a 1 year we will be able to show you a very nice case series how this has an additional effect in these sites where you would normally have to use a connective tissue graft. But what about hyaluronic acid and bone cells and bone formation? Now, how does it work there? We said something a little bit before, how it recruits and mesenchymal stem cells, how it works also on calvarial cells from the rat. And a recent review article on bone formation and application in dentistry stated that there's increasingly more attention to the clinical application of hyaluronic acid in dentistry. However, its effectiveness is inconclusive, and that there is a need for more well-designed clinical randomized trials with longer follow-up to see how effective it is, and that we will need additional information from laboratories. Now, a study like 11 years ago published, they looked at how does it have an effect on bone marrow stromal cells, and it seems that hyaluronic acid has an important role in the early and late stages of bone formation, and it also increases proliferation and osteogenic differentiation of bone mesenchymal stem cells, or bone marrow stem cells. And we see here, this is the alizarin red staining, and we see how if we pre-treat and treat these cells, they mineralized really very strongly compared to the basal or to the non-treated group of cells. So it definitely induces differentiation of undifferentiated stem cells into the osteoblast mineralized lineage. Additionally, we know that hyaluronic acid is very good as a carrier for growth factors, but additionally to that, it alone has the ability to induce osteoblast differentiation. So it not only that a combination of a growth factor, in this case like a BMP9 to the hyaluronic acid induces bone formation or mineralization of cells. It also by itself, which is seen here, so also by itself is able to induce differentiation of osteoblasts into the mineralized lineage. Hyaluronic acid, as well as we said before, it stimulates neovascularization during the regeneration of the bone marrow after ablation. And just to, again, repeat it one more time, so it is able to induce more blood vessel formation. And additionally, if you combine it with a biomaterial, it is able to significantly increase these pre-osteoblast cells. So the number of these pre-osteoblasts are significantly increased with the application of the hyaluronic acid. And additionally to that, if we see here the histology, we see that when the hyaluronic acid is combined with a bone grafting material, it significantly increases bone formation in this critical size defect. So the conclusion of this study is that low molecular weight hyaluronic acid is known to play an important role in bone regeneration, promoting differentiation, vascularization, and migration of mesenchymal stem cells. And according to some recent reports published in 2014, it was demonstrated that mesenchymal stem cells are migrated, granulated, and differentiated into the osteoblastic cells in the presence of low molecular weight hyaluronic acid. So there is definitely an effect of this molecule on cells that are going to become osteoblasts. So when we look and when we think about it, and when we have all of this information, then we can look at some examples of how we can treat these patients. So this is a patient with periimplantitis in 2012. And when we open the flap, we see huge bone loss around both of these implants. And usually I treat these implant surfaces with ozone. It has proven me very good and exceptionally good results. And then I used the barrier gel. This was in 2012. I used this barrier gel and placed it on the surface of the bone. Used the bone grafting material, coated it again to stabilize it with the barrier gel, sutured the wound. This is 2-week healing. And then if we compare 2012 to 2016, we see that we went basically from a 12-millimeter pocket on the buccal aspect to a 2-millimeter pocket, which is quite amazing. And if we look at the radiograph before and after, we can see complete bone fill, at least here between these implants where there was no bone, and here on the distal we see additionally better results. And I'll tell you, this patient is still coming to the office. Last time I seen him last year in 2018, and these results are still stable. Another periimplantitis case where this material could have potential. This was in 2014, so there is severe bone loss. There is marginal bone loss of more than 50% around these implants, so it's somewhere up to here. We see poor soft tissue around here, so we do all the non-surgical treatment to stop the inflammation. And in this case, we did a free gingival graft to somehow increase the amount of keratinized tissue, which is very difficult in the lower mandible when the crowns were here. It would have been much better if the patient removed these old crowns. And even with that, we had between, in a year span, we see a significant increase in bone gain only by this non-surgical therapy and the change in the soft tissue profile. But in 2016, there's a relapse again. And in this time, I decided at the beginning of 2017 to do a surgical procedure, which I will show you a video of. And we see here that the probing depths are not so big. It's around 4 to 5 millimeter here around these implants. But since the periimplantitis has reactivated, so I decided to go and open. The flap is something as a papilla preservation flap around the teeth. At least we have some keratinized tissue here left from the free gingival graft. The flap is opened. And the implant surface now, the granulation tissue will be debrided. So we remove this collar, which is usual. And then we did implantoplasty to remove as much as we can and something like a poncho over the implant. Over the implants, we first check it. This is the REGEDENT membrane, which I've been using frequently over the last, well, 3 or 4 years, maybe even 4 years. And then I did intermarrow penetrations here to make this site a little bit bleed. Bone grafting material. Only into the area where the intrabony defect was, and then applying the hyaluronic acid on the surface of these the bone grafting material to coat it, covered with a collagen membrane. And then we go periostal releasing the incisions, and we suture it. And then 18 months later, we see a complete change in 2.5 to 2 millimeters of pocket probing depth. And then if we follow the radiographs from 2014 to 2016 to 2018, we see that there is a complete resolution of the intrabony defects at the end. So this area here and this area here is completely mineralized with no bleeding on probing or very little, maintaining keratinized tissue. So I have to say I'm very surprised by these promising results, how this material is exceptionally good in these indications. If we go and look at how it functions on more difficult cases in bone formation, let's look at this patient. So obviously there's a problem here. So when we opened the flap, we saw external root resorption. We saw on the palatal side, we saw vertical fracture. So this tooth had to go out. We did suturing, and then we went back 6 weeks later. So the tooth was extracted. We placed a little bit of PRF inside, and we waited for 4 months. 4 months later, we will go now and see if you remember how there was no bone there was no bone before there on the mesial aspect here of this lateral incisor. So once we opened the flap, we saw a huge defect on the palate, and the implant should come here, and we see a huge vertical defect also. But we are lucky now because we have bone here. So we have bone here on the mesial aspect of this lateral incisor, and this gives us a chance to achieve exceptionally good bone regeneration. And if we go to a higher look, we can see the amount of vertical defect and the amount of palatal bone loss. And unfortunately, we see here where the incisal nerve is going out, so everything is going against us. So in cases like this, I like to use non-resorbable membranes in the maxilla, and we place a combination of an allogenic and xenograft grafting material, and then we coat everything with the hyaluronic acid, a thick layer of this coated all around to coat it so it's non-mobile and so it's well precipitated onto the bone grafting particles. We then go and stabilize the membrane, and I always like to place a collagen membrane, in this case REGEDENT membrane. I almost always use this membrane. It has proven me very exceptionally good. 6 months later, you see incredible amount of some formation with this always superficial layer of the pseudoperiost, which we can always find under these non-resorbable membranes. And if we look from the palatal side, we see that we can now position the implant in the correct three-dimensional position. And then after the healing period, we can go and play with the provisional restoration, scalloping the tissue. And once we get the tissue scalped and the gingival margins aligned, we go and we finish the crown with the final prosthetic reconstruction. Let's look at another difficult case. So this patient is a dentulous in this area. Here we see a very narrow ridge. And here in this case, if we look at the intraoral photograph, we can see that there's really very little bone here, very narrow, maybe 1.5, maximum 2 millimeters of bone width. Now, sorry, I'll just, music is always playing. So I always do these intramarrow penetrations, okay, because it allows new blood vessels to go. And if I place the hyaluronic acid here on the surface, it will integrate with the blood vessels. In addition, it will stimulate these bone mesenchymal stem cells that are coming from the bone, from the spongus region here. It will stimulate them to go into the osteoblastic lineage. So I do all of these intramarrow penetrations so that the recipient side bleeds very nice, and that there is a lot of bleeding here. I want to see a lot of bleeding here. And then I place the grafting material. In this case, we had to graft on the lingual as well as the buccal side. So we gently graft the material. We pack it. We want the bone surface, and then we coat it with the hyaluronic acid. So we use a lot of hyaluronic acid, and we coat everything so it's completely covered. And then we go and stabilize the membrane with the tacks. So this is how it looks when the grafting material is completely coated. So it stays very, very nicely stick here. It's very nicely stuck. And then we place the non-resorbable membrane, tack it. We take care not to be close to the periodontal ligament of the neighboring teeth. And if you look at 6 months later, we see massive bone formation here and massive bone formation here. So there's an incredible amount of bone formation when using this concept and with the addition of the hyaluronic acid. And very nice soft tissue. Additionally to that, there's thick soft tissue and exceptionally nice soft tissue, virtually no loss of keratinized tissue here in this area. And if we look at the final prosthetic work, and this is how the radiograph, at least for this canine here, looks like, and these two are also very nice. So if we look at the pictures before and after, we have achieved very nice horizontal and vertical augmentation, and achieved very thick tissue and very nice soft tissue with the application of this. Now, let's look at the last case that I want to show you. It's a case where if we open it, and if we open it, and we see that there is a width of only 1 millimeter. So this is a case where everybody would say you have to use the bone block, or you have to use a non-resorbable membrane, or you have to use a resorbable membrane with autogenous bone. But I will show you something new that we are working on. So again, intramarrow penetration, I like to see a lot of bleeding here, very much a lot of bleeding. So because all of the information that I gave you before, this is mandatory. And then we use the collagen membrane, we tack it. And let me show you how it's nice when you coat with hyaluronic acid. You see how the material sticks together? It doesn't fall off. It's unbelievably nice how it sticks together. So we place the material that is already pre-coated. with the hyaluronic acid, a xenogenic material here in this case, with a little bit of autogenous bone. And we additionally then coated everything with hyaluronic acid again, stabilized the membrane, and this is 6 months later. Now this is very thick between class 2 and class 3 bone, very thick bone. There's a lot of remodeling of the xenogenic bone. We see a lot of remodeling. We see the pins completely embedded, almost completely embedded into the new bone, and the implant placed very nicely, virtually in completely regenerated bone. Basically, it is almost entirely in the regenerated bone. Very nice table. And because we usually lose a lot of keratinized tissue, a free gingival graft was done in the meantime to get nice, thick, soft tissue and protect the underlying regenerated bone. And if we look at before and later, and if we follow the radiograph at baseline and 1 year after loading, we see that there's very nice maintained bone margin and bone levels here around the implant, and very stable, nice inflammatory-free conditions around this implant. So this is the way that I have been proceeding in the last 8 months, trying to utilize only the collagen membrane and the mandible. And we have done a very big number of cases, and soon these cases will come. Many of them will come from re-entry and histologic analysis, but these few initial results that I had, not only this case, but some other ones that have all shown this type of bone regeneration, have told me that this material is really promising as an additional aid in fast remodeling of the grafting particles, even if you don't have to use a lot of autogenous bone, maybe just a little bit, and you can do most of it with a xenogenic bone, with very thick bone and very bleeding bone, and it looks very nice. So my conclusion is that hyaluronic acid shows a potential as a molecule that is involved in numerous cell functions, from cell recruitment to proliferation and differentiation. From my clinical experience, it has the potential to speed up healing and provide promising clinical results, but it cannot work on its own. We have to remember that, and it needs a substrate or an additional growth factor to achieve greater results. So we need a bone grafting materials, even better, because we can then coat this material with the hyaluronic acid, and then the hyaluronic acid will release its activity into the surrounding from coated or pre-treated, as they want to say, biomaterials. What we don't know is that we don't know the exact amount and concentration of the hyaluronic acid that is needed to elicit a regenerative cascade of actions, and this needs further research. So I cannot tell you how much is necessary, 1 milliliter, 2 milliliters. Should we place a little bit, a lot? I know that I place a lot. I coat significant amounts of hyaluronic acid over once the grafting material is placed. And these promising and encouraging initial results on our ongoing clinical trials in our clinic will give us more results into the possibilities of this molecule as a factor that truly promotes regeneration in different indications in dentistry, going from recession coverage, periodontal regeneration, and especially bone GBR, guided bone regeneration. And with this conclusion, I would like to thank you very much for your attention, and I'm ready for your questions.
So, hello.
Hello.
If you have questions, you can or ask directly, but I think it's easier maybe if you use the chat, so Professor Božić can see them and then give us an answer. I don't know if everybody can see the chat line. It should be, if you go on the bottom of the Zoom, you can see there is a little icon with written chat. And
okay, so the first question is, do I have do I have experience in papillary regeneration? I have not done any cases of that. I have 2 cases that I'm going to try. You have 2 publications on papillary regeneration. One is by Becker a long time ago with the hyaluronic acid. They published in the Clinical Oral Implants and Related Research. It has been, they have shown that there is a beneficial effect by applying the hyaluronic acid in the papillary region. Another one was recently published by Stavropoulos and his group in Clinical Oral Implants Research. And they have not had such good results at the first study of the Beckers. So I have seen a PhD publication, and it seems in this PhD, they had very nice results in papillary regeneration. So we will see in the future how good it is. I will try it for sure, but unfortunately I haven't tried it yet. I do leave pins. It is not a problem. And I have no problems of leaving pins inside. Many of the pins are completely embedded in bone, so I can't even find them. So that's the reason. If I see them, I use magnifying, quite large magnifying glasses, 3.4, and I still cannot see them. So in many cases, they are completely embedded in bone, so that's why I don't leave them. All of them that I see and that I can remove, I do remove. Well, thank you very much, Laura Lobianco, for saying that it is a very interesting lecture. Paolo Ricci asked, do I place the implant in a second moment or during the regeneration? It depends what type of a membrane I use. I prefer doing 2-stage. I prefer using first creating bone and then placing an implant. Now, that said, I do use a lot of titanium mesh, and when I use the titanium mesh, I place the implant and the titanium mesh in 1-stage procedure.
There is one person who wants to say something. I think it's Dr. Patrizia Novello. Maybe if
okay, thank
can
you.
Give her through, let's say, give her the voice.
Okay.
Just a second. I'm asking the administrator if it works. Lucia, does it work?
Yes, but I don't know if Dr. Novello has turned off the microphone.
Can you turn off just?
Now it's free. Maybe she's not there anymore. Okay.
Maybe we should go to the, I don't know if are the next other questions. Lucia, are there other questions coming in?
No, I don't have any hands on,
okay.
Which I have to.
Okay, there's a question. Do you use it with the external sinus elevation? I have not used the hyaluronic acid with the external sinus elevation, not so far. I have concentrated on the cases that I have showed you, GBR in the mandible and the maxilla, and try to decrease the amount of bone harvesting if we can to decrease the bone harvesting and to see if we can make it simpler and more user-friendly. So, but I'm almost positive that in the external sinus elevation, it will work perfectly. I'm only not sure that if you only place the gel instead of a membrane on the lateral wall, the window that you create, that it will be sufficient. So I would still go, I'm not so sure. So I would advise that you still place a collagen membrane over the window of the external sinus. Thank you, Domagoj, for your nice comments about the lecture. Do I think that it prevents exposure of membranes? I think so, yes. I think what I have noticed is that it really speeds up soft tissue healing. I'm even if you do the surgery perfect, I would always use this material to close the wound. I haven't showed you, but I always coat the wound. Once I suture everything, I coat the wound again with the hyaluronic acid and leave it there for, let's say, 10-15 minutes until patients not to rinse, so that it impregnates, so that it attaches to the fibroblasts. Could Emdogain work with hyaluronic acid? Well, maybe. I don't know, but they definitely have completely different ways how they work. So there could be a difficulty in, there could be that they work synergistically, but they also could be a difficulty maybe that they decrease the effect of each other. Did you use without bone grafting material, just with autogenous bone? No, I have not used it without any grafting, only with autogenous bone, because my idea is that I want to decrease the amount of harvesting of autogenous bone. And if this helps me to decrease, then it is okay. Did you use the non-resorbable membranes on top of them below the flap? If you remember in those cases where I needed vertical augmentation, I used a non-resorbable membrane, and then above that, I used the resorbable membrane to protect it. In the case in the lower mandible, where that canine was, I used only the non-resorbable membrane without any use of a resorbable membrane. Do I have any experience with flap perforations in hyaluronic acid? I did have one flap perforation, and I can tell you that it seemed to me that it definitely helped in protecting this place. It protected this place where I had the perforation of the flap, so there was a faster healing of that. Do I think it can replace the PRF? I have to say that I am not very favorable. I'm not the address to ask about PRF. I think PRF is definitely a material that it works in some indications, such as the extraction socket, but the PRF is basically a fibrin membrane, and it disintegrates in 7 days. So I don't know, and the hyaluronic acid stays in the site between 6 and 8 weeks. So it's completely different. You have something that has very low amount of growth factors in it, such as the PRF, and it dissolves in maybe 10 days maximum. So it's really not such a strong membrane. It helps in soft tissue healing, but I wouldn't say that it exerts a lot of effect on osteoblasts and things like that. So, I don't know about this. There is a study by the South African. Yes, that's true. A combination of the PRF and the hyaluronic acid published in the South African Dental Journal, and definitely the PRF works only for 7 days. That's the thing. Hyaluronic acid works for 6 weeks. Stays there for 6 weeks.
Okay. Are there other questions? If there are no questions, first of all, I want to thank to all the participants who haven't listened, but especially as well to Professor Božić. Thank you a lot for all the time and to share your experience from a clinical point of view, what we cannot do. And yes.
There are some few questions. Can I just quickly ask? So there's a thank you, Nicolis, Andrea. Thank you for your nice, kind words. To Serena Ferroni, do I use hyaluronic? How do we use hyaluronic acid in sinus lift? It is a liquid material, and you need a bone grafting material to keep the membrane not compressing back to once you lift it. So I would say that in the sinus, the hyaluronic acid could be nicely beneficial basically in the sinus, whatever you place, bone develops. So I would rather go for more difficult cases such as knife-edge ridges, periodontal regeneration, full maxillary arch restorations, where you need to harvest a lot of autogenous bone. This is the main indication where we want to see this. I would say it is a growth factor to a certain extent, but let's say this molecule to see if it helps us.
Okay.
Okay.
More questions? Okay, so it seems that we have answered, or you have answered all the questions we have just listened. Many thanks to everybody. Many thanks, especially as mentioned before, to Professor Božić for the time to share the experience with us. And we are very grateful to work with you. Many thanks, and I wish to everybody a nice evening.
I would like to thank everybody that has participated here in this discussion and listened to the lecture. And I would like to thank REGEDENT for inviting me to give this lecture and show some of the clinical experiences that we have. And in the future and in the next year, especially, let's say, in the Periodontal Master Clinic that will be in Dublin, I will show you many more results and show you a longer-term follow-up of some of the cases. And it is an exciting material, and I'm really happy that I started working with it. So thank you very much, and I hope to give a lecture soon somewhere else. I don't know. Thank you very much.